Good afternoon, everyone, and welcome to this week's Insight webinar series, ICD10 and Your Bottom Line. This week, our presenter is Ashley Giaquinta. Ashley is a project specialist at CareOptimize. She's been working with healthcare for about 12 years. She's a certified coder with a background in revenue cycle management, and she specializes in coding and physician education, so she's very well qualified for this presentation. Without further ado, I will turn it over to Ashley.
Thanks, Jan. Welcome, everyone. Today we are going to talk about a few things and what has changed as of 10/1 with some of the new ICD10 rules and guidelines. Some of the things we're going to discuss today is key changes and revisions, written guidance from CMS and OIG that may negate a new guideline, chapter-specific changes, and how to tell when you need documentation and when you don't. One of the first changes is for the word with and how it's interpreted. The word with should be interpreted to mean associated with or due to when it appears in a code title. It is to presume a causal relationship between the two conditions linked by the terms in the alphabetical index. For conditions that are not specifically related or linked, the provider will need to document in the record that states these two conditions are not related. If a condition is related, associated with, or due to, it presumes a causal relationship. Physician documentation is not required to state that it is related. You are allowed to presume the causal relationship. An example of this would be diabetes. For a patient that has diabetes with a cataract, you can presume that the cataract is specifically related to the diabetes, and that's how you would code it. If the patient, for example, has chronic kidney disease as well as diabetes, and the provider puts in the medical record that those two are not related and don't have a causal relationship, you would then code those separately. Another change with code assignment and clinical criteria. The assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Code assignment is not based on clinical criteria used by the provider to establish the diagnosis. So when a patient's being seen, the workup phase of that visit, you would not use that part of the visit to code. You would, whatever the provider says that the patient has is sufficient enough, and that's how you code that visit. Part of the 2016 OIG work plan, the OIG said that they were going to review medical record documentation to ensure that it supports diagnoses that were submitted by Medicare Advantage organizations for the use in risk score calculations. Prior OIG reviews have shown that the medical record documentation does not always support the diagnoses submitted to CMS by the Medicare Advantage organizations. They are required to submit risk adjustment data to CMS in accordance with the HHS OIG work plan fiscal year 2016. Payments sometimes to the Medicare Advantage organizations are adjusted on the basis of the health status of each beneficiary. So when inaccurate diagnoses are recorded to CMS, it could cause improper payment amounts to the Medicare Advantage organization. Specific coding is now. In a question that was proposed by a provider's office, they asked Medicare, are they going to phase in the requirements to code to the highest level of specificity? CMS response to that was, no, providers should already be coding to the highest level of specificity, and that as of 10/1/2016, providers are required to code to accurately reflect the clinical documentation. So when ICD-10 came into effect, specificity didn't just start, when ICD-10 came into play. Specificity should have always been happening, even with ICD-9. It's just now with ICD-10, there's more options to choose from, more specific codes to choose from, to describe the kind of care that you are giving your patients, and which is really good, because once we move from fee-for-service to value-based care, you're going to want to report all the time that it takes for you to take care of that patient, with the diabetes, with the hypertension, are there comorbidities involved in chronic conditions? So coding to the highest level of specificity didn't just start, it should have always been happening. So now as of 10/1, those code freezes and, the lacks of reporting unspecified codes is, not going to be appropriate any longer. So we really need to be coding as specific as possible. When it comes to sequela, which is also known as a late effect, it's a residual effect after the acute phase of an illness or injury. There's no time limit for a sequela code, and the residual effect from the sequela could occur within days, months, years, and it's usually sequenced with 2 codes: the condition or the nature with the sequela, followed by the actual sequela code. The code for an acute phase of an illness or injury that led to the sequela is never used with a code for a late effect. Now, there is an exception to the rule if the code for a sequela is followed by a manifestation code identified in the tabular list, or the sequela code has been expanded by the 4th, 5th, or 6th character levels to include the manifestation. So some examples of sequelas include a scar formation resulting from a burn, a deviated septum due to a nasal fraction, and infertility due to tubal occlusion from old tuberculosis. And just a quick note that the code for the acute phase of an illness or injury that led to the sequela is never coded with the late effect code. Something new that started October 1st of this year was the NPD designation, which means not a primary diagnosis. So any code that ends with S and T from Chapter 19 that requires the 7th character of S or T will receive a designation of NPD in the Commercial Clinical Editor. This affects 9,600 diagnosis codes from Chapter 19, which currently do not have the NPD designation. And so this is based on a recent clarification from the American Hospital Association. So for specific documentation, some things have changed in regards to BMI, depth of non-pressure ulcers, pressure ulcer stage, coma scale, and the NIH stroke scale. Code assignment may be based on medical record documentation from clinicians who are not the patient's provider. So, i.e. a physician or an other qualified healthcare practitioner, someone who is legally accountable for establishing the patient's diagnosis code. So that could be your nurse practitioners, your physician assistants, and sometimes when patients are, seen, there are, other people documenting that information. So, for example, when a patient comes in for an office visit, sometimes it's your clinical staff that gets the height, the weight, the BMI, and, an emergency medical technician often documents the coma scale. So the issue lies with the associated diagnoses with these, so overweight, obesity, acute stroke, or pressure ulcer. that must be documented by the patient's provider. If there is conflicting documentation in the medical record, either from the clinician or different clinicians, the patient's attending provider should be queried for that clarification. So a couple of examples are the nurse documents the patient's weight, height, and subsequent BMI data. The physician doesn't state that the patient has obesity. So if the physician did not state obesity in the record, you should not code the obesity diagnosis. If the physician documents that the patient has obesity, then the obesity code can be used. Documentation of complications of care. Code assignment is based on the provider's documentation of the relationship between the condition and the care or procedure unless otherwise instructed by the classification. This extends to any complications of care or conditions that occur during or following medical care or surgery and are classified as complications. There has to be some type of cause and effect relationship between the care provided and the condition, and there needs to be an indication in the documentation that this is a complication. If it's not very clear or your provider didn't document that, always query the provider for clarification if it's not stated. There's a change when it comes to excludes one exception. An exception to the excludes one definition is the circumstance when the two conditions are unrelated to each other. If it is not clear whether the two conditions involving an excludes one note are related or not, query the provider. An example of this would be code F45.8, other somatoform disorders. It has an excludes one note for sleep-related teeth grinding, which is code G4763. Because the teeth grinding is an inclusion term under F45.8, only one of these two codes should be assigned for teeth grinding. However, looking at the code, psychogenic dysmenorrhea is also an inclusion term under code F45.8. So a patient could have both of these conditions, and in this case, because the conditions are clearly unrelated, you can code both diagnoses. When it comes to laterality, some of the ICD-10 codes indicate laterality, specifying whether the condition occurs on the left, right, or is bilateral. If the bilateral code is not provided and the condition is bilateral, assign separate codes for both the right and the left side. If the side is not identified in the medical record, you're to assign the code for unspecified or query the provider. So when a patient has a bilateral condition and they're being treated and they come in and the condition exists on both sides during that encounter of treatment, you will use the bilateral codes. An example of this is cataracts. Most of the time when people have cataracts, one eye is treated at a time. So initially they come in, they see the doctor says, yep, bilateral cataracts, that's what goes out on the first claim. They come back again, they have surgery on the right eye. The second claim that would go out would be cataract right eye. Then they come back again, have the left side done. You would only code cataract left eye. If the condition still exists on both sides, there was a problem with treatment, there was a problem with surgery, then you could still use the bilateral code. Now on to some chapter-specific changes. For the Zika virus, you're going to only code confirmed cases of the Zika virus as documented by the provider. A clear confirmation does not need to be documented as to what type of test was performed. If the physician says that the condition is confirmed or positive, that is sufficient. If the provider documents suspected, probable, possible, you're not going to use the Zika code A92.5. You're only going to code the associated signs of symptoms, i.e. nausea, vomiting, diarrhea, whatever applies to that particular encounter. For hypertension crisis, assign a code category from I-16 hypertensive crisis for documented hypertensive urgency, hypertensive emergency, or unspecified hypertensive crisis. Code also any identified hypertensive disease, codes I-10 through I-15. The sequencing is based upon the reason for the encounter. Acute myocardial infarctions. For encounters occurring, mild myocardial infarction is equal to or less than 4 weeks old, including transfers from one acute setting to another or a post-acute setting, and the myocardial infarction meets the definition for other diagnoses. You're going to see Section 3 reporting additional diagnoses. Codes from I-21 may continue to be reported. Pressure ulcers. For ulcers that were present on admission but healed at the time of discharge, assign the code and site and the stage of the pressure ulcer at the time of admission. So they come in, they have the ulcer, they leave, it's healed. You're still going to use the code for that initial admission. Supervision of a high-risk pregnancy. Codes from category 009, supervision of a high-risk pregnancy, are only to be used during the prenatal period. If the high-risk pregnancy complications during labor and delivery, you're going to use the applicable complication codes from Chapter 15. If there were no complications during labor and delivery, you're going to use 080 for encounter for full-term uncomplicated delivery. When a delivery occurs during an admission, the condition prompting the admission is sequenced as the principal diagnosis. Multiple conditions prompted the admission. Sequence the one most related to the delivery as the principal diagnosis, and any other additional complication during delivery should be sequenced as additional diagnoses. So if a patient comes in, they have preterm labor and they're also hypertensive, maybe the provider gets the contractions under control but can't quite get the hypertension under control, and they decide, you know what, this is best for the patient to deliver because of the hypertension, then that would be the primary diagnosis code. For gestational pregnancy-induced diabetes, the codes that are under category 024.4, that includes diet-controlled, insulin-controlled, and controlled by oral hypoglycemic drugs. If a patient with gestational diabetes is treated with both diet and insulin, you're only required to report the insulin-controlled. If a patient is treated with both diet and oral hypoglycemic medications, only code for controlled by oral hypoglycemic drugs is required. So you don't need to use both diet and hypoglycemic meds. Only code for controlled by oral hypoglycemic drugs. And then 024.2 should not be assigned with codes Z79.4 or Z79.84. For observation evaluation of newborns versus suspected conditions not found, you're going to assign a code from category Z05 for observation and evaluation of newborns and infants for suspected conditions ruled out. And this is to identify any instances where a healthy newborn is evaluated for a condition that they thought may have been found during delivery and that was ruled out. And if they still continue to have signs and symptoms of that suspected problem, you're not going to use code Z05. For the coma scale, the coma scale codes R4, 0.2, and so on can be used in conjunction with traumatic brain injury codes, acute cerebrovascular disease, or sequelas of cerebrovascular disease codes. These codes are primarily for use by trauma registries, but they may be used in any setting where this information is collected. The coma scale may also be used to assess the status of the central nervous system for other non-trauma conditions, such as monitoring patients in the ICU, regardless of the medical condition. The coma scale codes should be sequenced after the diagnosis codes. When it comes to the NIHSS stroke scale, these codes can also be used in conjunction with acute stroke codes from category I63 to identify the patient's neurological status and the severity of the stroke. The stroke scale codes should be sequenced after the acute stroke diagnosis code. At a minimum, you can report the initial score documented. If desired, you may choose to capture multiple stroke scale scores. And these are the correlating diagnosis codes to the stroke scale score. Seventh character A. Seventh character A, initial encounter, is used for each encounter where the patient is receiving active treatment for the condition. When it comes to fractures, initial versus subsequent, the open fracture designation and the assignment of the seventh character for fractures of the forearm, femur, and lower leg, including the ankle, are based upon the Gustilo open fracture classification. When that classification is not specified for an open fracture, the seventh character for open fracture should be assigned with either B, E, H, M, or O. And that concludes our presentation for today. If you have any questions, please feel free to email me. I've included my email on the slide, and thanks to everyone for attending today.
And also, CareOptimize has a newly updated website, so please feel free to visit our website. Thanks. Bye-bye.